Hi guys, I'm Dr. Gyaneshwari Raika, and this is my demo class on ABG interpretation. So let's begin. So why did I select ABG interpretation is because one, it is a very important important skill to know clinically, and as a junior doctor you need to you need to know how to interpret an ABG. um, Secondly, it's a very frequently asked question in the board exams. Either they ask you with the case, either they ask you with these arrows telling you what parameters will change in this particular situation, or how will it get compensated, or how, or in any which, in some sort of way, ABG is a part of the question. And as we know, competitive exams don't give us a lot of time to think, so you need to really know how to do this fast. I think ABG is simple when you think of it logically, and if you follow a few rules, it becomes very simple to interpret it. So let's just start. So as I said, ABG is air blood gas. It's a very important skill to know clinically and practically. Um, what is it exactly? It's basically a blood sample that you take and you place it into an ABG analyzer, and it tells you what exactly is the concentration of oxygen, carbon dioxide, and bicarbonate in the person's blood. Okay, so why is it important? It's important because when you have a person coming into the emergency, excuse me, or you are in an acute setting like an ICU, the person starts looking, sick than usual, or the person looks sick on first observation, on first inspection, and you are wondering what's happening with this person. Maybe you're not sure. Maybe you just want to know more. Say the person's short of breath, you want to know more, right? So ABG becomes a very important investigation. It's not an investigation, but an important part of that investigation initially. So it would be wrong to call it a test. It's basically a sampling. You sample the blood from your radial artery, and then you take it to the analyzer. You put it in, and it analyzes the blood for you. So that's how it is. And you get this piece of paper that shows you the pH, shows you the carbon dioxide, shows you the oxygen, and shows you the bicarbonate. And you have these values, and you have to interpret what is happening to the patient. Okay. What are we looking at in this paper now? We're looking in this paper to see if this person maybe is hypoxic, and if he's hypoxic, then is he undergoing respiratory failure? If he's not hypoxic, is he hypercapnic? If he's hypercapnic, then is he undergoing respiratory failure? How is his pH? How is his blood acidity? If his acids are high or acids are low. All of this plays a very important role physiologically into our body, and correcting those parameters becomes very, very important. I'm not going to discuss how the pathology and the physiology of of respiration and hypoxia and metabolic acidosis. So for that, probably we could do a one-on-one class for those particular topics. But for now, it's just straightforward ABG interpretation. So first step of interpreting your ABG is to know your base values. This is key. Why is this key? Is because many a times you don't have time to see you generally have the normal range at the side, but you don't have time to see it. It's much simpler when you see the parameters and you know the normal range in your mind. Sometimes if you are doing examinations like the USMLE, or you're doing the examination like the PLAB, you have cases that are given to you on the telephone. This also happens clinically. So if you're a duty medical officer and someone calls you and says, we're giving you a patient and the patient's vitals are so and the ABG is so, you need to know your normals in your head, right? To understand and to assess what can you do for the patient. So it's a very important thing to know. But if you're going for an exam and sometimes if you don't know, it's always nice to refer to the normal range. But always better to know these values in your head. It saves time. So the first value we're looking at is oxygen. So this is the oxygen present in your atrial blood. That's 75 to 100. It does not go below this. In fact, doesn't go below 80, 95, 96, 94, below 90s, and you are not happy with the value. So it's actually 75 to 100 is normal value. Then your PCO2, which is 35 to 45 millimeters of mercury. That is a very important number you need to know. Your pH ranges from 7.35 to 7.45. Your bicarb from 22 to 26. And you have this lower value called base excess. What is base excess? Base excess is basically given with bicarb. So if you see ABG strip, you'll see the bicarb and you'll see the BE written down, which is base excess. It's basically telling you how much bicarb is in the solution that's more than the normal value. Okay, when is it important? It's important when it is out of this range, right? If it's out, if it's -3 or +3, for instance, and there's a metabolic element into it, so it can be either primary or it can be a compensatory move. But any which way, base excess, not to worry if you have bicarb in your bicarb values with you, and they don't give base excess. Another thing to tell you, there is something else called as a VBG, which is venous blood gas. Venous blood gas is a sister sampling of ABG, atrial blood gas. The difference is you're going to have a low oxygen level or a low saturation level. So it's very good in telling you acidosis and alkalosis. Not so much for respiratory issues, but it can be used when you know the person's breathing fine and you just need to know what's happening. Let's go ahead. So here's a small case. A 63-year-old female comes to the ER with shortness of breath. She appears drowsy. Her ABG shows a PO2 of 52.5, a PCO2 of 68.2, a pH of 7.29, and a bicarb of 26 milliequals. So this is like, okay, my case is really small, it's just one line, but generally you're going to have this elaborate case with her vitals. So you'll have this lady coming in with SOB, her vitals are so and so, she has a history of diabetes, she has a history of COPD, she's been blah, blah, blah. You read through all of that and then you come to your values, right? And you've lost half a minute on your clock and you're wondering, oh my God, I don't know how to interpret my ABG. And the options will be, what is happening with this lady, right? Or what is the compensation that you will see? Or what is the first step in your management? Any which way, key is to interpret your ABG. So let's see how we can do this. So to interpret ABG, just remember this in your head. So you see ABG, stay calm, don't worry. And the first thing you need to do, first thing is go see the pH, right? Look at the pH. See where the pH is shifting, right? If the pH is going low or the pH is going high. So the pH is below 7.35, it's low. That means the person is acidotic, right? If the pH is above 7.45, the person is alkalotic. So the first part of the puzzle is clear. acidosis, alkalosis. pH is low, pH is high. Many times you'll just have arrows. So you have pH, arrow, arrow, arrow. So you go like pH is going high, pH is going low. Where is it heading, right? So the first thing you need to see is the pH. Another important thing to remember is that many people, instead of pH, put the H plus sign, right? H plus is hydrogen ions. Hydrogen ions increases the acidity of blood. So if the hydrogen ions are higher, it's higher acidity, which means the pH will go low. So the high hydrogen ions lower the pH, right? So that's just to remember, but for now let's stick to pH. Okay, so pH is low, acidosis. pH is high, alkalosis. Second step, look at the bicarb. No matter where it is, right, you're going to have all these values stacked on top of each other. You need to go and find what you want. So you look at the bicarb. Now you know that this is, supposing the pH is low, right? Say he's acidotic, so he's in acidosis. Now you're looking at bicarb to see if it is metabolic or not. Okay, so in an acidosis situation, bicarb will get exhausted. You should see a drop in bicarb if it is metabolic. So if the pH is low in acidosis and the bicarb is low in acidosis, this is a metabolic acidosis. You don't even have to do step 3 and step 4. Probably step 4, but no step 3 involved. Okay, so simple. So metabolic acidosis is that simple, right? If the pH is high, alkalosis, and first step was to see pH, second step, see the bicarb. If the bicarb is high, that means the person has metabolic alkalosis, right? No need of step 3 and no need of step 4. Okay, clear? It's very simple. So now, if supposing your pH is deranged, it's low, and you have a normal bicarb, then you go to step 3, which is look at carbon dioxide. So if your pH is low, which is acidosis, your bicarb is normal, metabolic element not there, you're going to see carbon dioxide. If the carbon dioxide is high, it is respiratory acidosis. It has to be also because your bicarb is normal, right? It's not decreased in any sort of way. So it is acidosis, which is respiratory. So it's respiratory acidosis. Again, if the pH is high, alkalosis, normal bicarb, right? Step 2, step 3, carbon dioxide. Your carbon dioxide is low, it is respiratory alkalosis, right? Now step 4 is looking at oxygen. Why are we looking at oxygen? Of course, you're looking at oxygen here because you need to know whether there's a respiratory, whether this person, you look at the metabolic acidosis, alkalosis, yeah, I interpreted that. But in a clinical scenario, you also have to make sure that this person has hypoxia, no hypoxia. Do we need oxygen in the scenario? So that comes in by seeing your oxygen. So you need to look at your oxygen to see if it's in the normal range or not. Okay. Now let's go back to the case and apply our rules. Right? So 63-year-old female comes to ER with SOB and she is drowsy. So you know that there's shortness of breath, right? So you know there is something up with her respiratory system. So you first look at pH. The pH is 7.29. This case, I took it from a very good source and they had the normal values at the side. Let me reassure you guys with that. I haven't put it here because I want you all to first pause and think of the normal values. It's very important to get your brain wired that way. Okay, so pH is 7.29, which means it is acidosis. Now first step done. Step number 2, look at bicarb. Bicarb normal is 22 to 26. Bicarb in an acidosis situation, if it's metabolic acidosis, should be below 22. But this is way above 22 and it's normal range for me. So I am going to look at carbon dioxide. Now my carbon dioxide is 68.2, which is way higher than 45. that tells me this is respiratory acidosis. Clear? Very simple. So one key thing, we have a lady with shortness of breath. She's an old lady. We have a high carbon dioxide. She's retaining carbon dioxide. Now we need to see if she has any feature of respiratory failure. So you're going to look at oxygen. Now if you look at oxygen, oxygen is way lower than her ideal value, right? It's 52.5. Normal is 75 to 100. This tells me she is in a hypercapnic situation, which means high carbon dioxide and low oxygen. So hypercapnia, and she has respiratory failure type 2. This is respiratory failure type 2. Type 1, you're going to see hypoxia with a normal carbon dioxide. That means her ventilation system is fine. Here her ventilation system is not fine. Most probably she is a COPD patient or probably pneumonia patient. We don't know more from the history, but that's how you can actually analyze this. So clear? It took me less than a minute to see the case and analyze and interpret it, right? So let's go ahead. Case number 2. A 26-year-old boy comes to the ER complaining of breathlessness and perioral tingling. His vitals are stable except for an elevated respiratory rate. ABG are as follows. We have a boy who comes in with breathlessness. He's got an elevated respiratory rate. He also has perioral tingling, right? From the case, I can say this guy most probably has a sort of panic attack, but let's not draw conclusions here. The ABG tells us that his pH is 7.5. This is clearly way above normal, so alkalosis. His bicarb is 23 milliequals. Oh, 23 milliequals. Very close to the lower end. Yeah, but do we expect a low bicarb in an alkalotic situation? No, we're expecting a high bicarb, higher than normal, above 26. This guy has a normal bicarb, right? So now we're going to look at the carbon dioxide. Carbon dioxide is low, 29, way below 35. So this person has respiratory alkalosis. So that tells us that this person has respiratory. Okay, so coming back to the case, let's look at his oxygen. His oxygen, for such a low carbon dioxide, his oxygen is quite good, right? So definitely this guy has been hyperventilating. He's breathing in and exhaling a lot of carbon dioxide. Hence, he's in respiratory alkalosis. All I can do for this patient is give him a bag to breathe in to allow his carbon dioxide levels to come back to normal and hope that he breathes out of his panic attack, right? And some comforting words also. Let's go to the next slide. So I hope it's become very simple to understand what how it is to interpret the ABGs. So let's just head to the next part. Let's talk of compensation. So when I was in medical school and I had to learn these formulas which said that at one point for this many numbers of bicarb or this many number drops of carbon dioxide, you're going to see this much rise in bicarb and so on. So well, it makes things more complicated. It's easier to understand when you have a logical pattern. So let's see if this explains it. Okay, so primary disturbance is the first thing that has happened, right? So if we have a person with metabolic acidosis coming in, here's my cursor. Yeah, metabolic acidosis, you're gonna have a low pH, right? So low pH, then you see bicarb, bicarb will be low. This tells us it is metabolic acidosis, right? The acidosis because of pH low, low bicarb, metabolic, right? And initially, so you look at a person who's coming in the acute time of acidosis, carbon dioxide will be normal. This is it, in clinical scenarios, in real life scenarios, this is very rare because carbon dioxide, because the respiratory system reacts very quickly. It reacts within the first within the first 30 minutes. So you're going to see a drop in the carbon dioxide, or you'll see it in the low normal ranges at least. Okay, but let's say this guy takes his sweet time and comes in when situation is bad. For instance, in DKA, right, you have these diabetics who come inside the clinic, not clinic, in the ER, and you're going to see this person looking sick, appearing sick, drowsy. You take the vitals, they're all over the place, and they have the classic Kusm's breathing, right? Deep, fast breathing. And you check the blood sugar, it's above 300, and you're like, this guy is in the DKA, right? So DKA is basically acid accumulation, hence metabolic acidosis, and as a result, the carbon dioxide is being exhaled very, very quickly. So your expiratory phase of respiration will be long, and hence the compensation. But that's not enough. That's not enough. So in such a scenario, you're going to see the person having a low carbon dioxide. Hence, that's compensation. So the body for metabolic acidosis essentially throws out all the carbon dioxide in some sort of way, creating a respiratory alkalosis. Okay, but it just throws all the carbon dioxide outside. Okay, now respiratory acidosis. You have the pH that is low. Okay, bicarb is normal, right? And then you look at carbon dioxide is high, right? This is an acute scenario, right? This happens in clinical setups because the kidneys tend to react slower and takes a longer time. Hence, you see such a scenario very, very, very easily. And you're even worried whether this person has respiratory failure. So this scenario is quite common. So high carbon dioxide means respiratory acidosis. And later on, let's say this person comes in way later, right? A chronic retainer, for instance, you'll see a high bicarb. Why? Because the blood is compensating for that acid retention, right? So it's it's increasing the amount of bicarb and flushing all the hydrogen out of the body through the kidneys. So you're going to see a high bicarb beyond its normal range. Okay, when I say low, I say beyond its normal range, not in normal range. When I say normal, I mean the normal range. That's why it's so important to know your range, right? So this is higher than normal range. Okay, and this is very clear from the first two examples that in primary disturbances, your bicarb and your carbon dioxide are almost opposite in direction, right? So you have the bicarb going low, carbon dioxide is normal, right? Similarly, your carbon dioxide going high and your bicarb is normal, right? So in primary disturbances, you're going to see shifts in the opposite direction, okay? Either not one going up and one staying stable, or in the opposite direction. However, when you see a compensatory phase, you're going to see both carbon dioxide and bicarb moving in the same direction. You'll see a low bicarb, you'll see a low carbon dioxide. You'll see a high bicarb, you'll see a high carbon dioxide, a high bicarb in compensation. So they both move in the same direction. So if you see a chart and you see like the carbon dioxide responding being low, you know that this person is compensating, right? So next slide, which is next point is metabolic alkalosis. Your pH is high, Your bicarb will be high, and hence carbon dioxide will be normal and later on go high. See, again, either primary disturbance, opposite directions, secondary disturbance, same direction, right? Secondary disturbance or secondary compensation is in the same direction. Sorry, not secondary disturbance, secondary compensation. And yeah, now key is whether the person is partially compensated or fully compensated. When do you know that? Well, it's very simple. As and when the body is very smart, so it wants to just neutralize, right? It doesn't care about these parameters initially. It just wants to compensate and neutralize to maintain status quo in the body. So what it does is, pH is low, it starts signaling the kidney, it starts signaling the buffers in the kidney, and it signals the, you know, the respiratory system, and fluctuations happen. So the pH is low, and then your bicarb is also, because of, say, a high amount of acid in the system, then your lungs are essentially just exhaling too much to allow the carbon dioxide to go out, right? And it's doing this because, excuse me, to maintain. So if supposing you get this person and you see to maintain the pH, right? So you get this person in and you see that this person's pH is low and this person's parameters are moving in the same direction, but it's still not the pH is still not in the normal range. This person is partially compensated. If the person's pH is in the normal range and the parameters are moving in the same direction, but they're deranged, right? This person is compensated, right? A compensated person is less scarier than an uncompensated person, right? But that's key. If you have a compensatory response and the pH is not in normal range, you are in a partial compensation. If the person is compensating and the pH is in normal range, you have a fully compensated person. So that is what compensation and metabolic acidosis, alkalosis, respiratory acidosis, alkalosis is all about. Another case, a young woman comes to the emergency complaining of vomiting this morning. On examination, she is tachycardic and is drowsy, hypotensive, and she's started on IV fluids, right? Her ABG shows the following. pH is 7.55, bicarb is 28, and PCO2 is 38. So it's a quite straightforward case. We have a woman who's vomiting, so she's removing all her acid out. Clearly from the case itself, we know that this one should be in metabolic alkalosis, right? She's tachycardic because she's vomited so much of fluid, hypotensive, again because of fluid, lack of fluid, and you're giving her IVs, right, to stabilize that. Her ABG shows alkalotic picture, so very similar to the vomiting history. So those are the clues you get from the case, right? So you have her vomiting, expecting metabolic alkalosis. Her pH is 7.55. Her bicarb clearly is higher than normal, it's 28, so this is metabolic, and her PCO2 can be seen to be as 38, right? It's in the normal range, right? So she is in metabolic alkalosis. Now the next line says, what compensatory change will you expect the body to do? Okay, so it's asking us that she is in metabolic alkalosis. What shift the body is going to do to make sure that the acidosis, or sorry, the alkalosis is neutralized, right? So because it's alkalosis and you want the pH to return to normal, you're going to increase the acid in the body, right? So you're going to see a acidotic shift. So you're going to see your body moving to acidosis, right? Second, if she is in metabolic alkalosis, which system can help us out? It's the respiratory system. So you're going to see a respiratory acidosis. So I'd go for my respiratory acidosis. Well, to explain it in the compensation mechanism, so her bicarb is high and her acid and her pH is high, right? Now my body, if I am a person, I am that lady who's vomiting, my body will clearly try to retain the acid in my body. The first thing I do is I trigger my buffer systems, right? But buffers last for very short period of time, and that will not help enough. So the alkalosis will be sensed by my chemoreceptors. My chemoreceptors in turn will signal my lungs to breathe slowly, hence hypoventilation, which will help me retain my carbon dioxide. If my carbon dioxide is retained, I'll see a carbon dioxide lift in this ABG, and hence that is compensation, and hence that is how the body is going to get back into its or neutralize its pH. So yeah, that's about it. I hope you guys have liked the presentation and liked this short class over interpretation. Hope to see you guys soon, and that's about it. Thank you so much.